antithrombotic treatment. Graham?
Well, thank you very much indeed, Professor Chairs. It's a pleasure for me to join you here this afternoon in Barcelona. I'm going to discuss with you future challenges with respect to the new anticoagulant drugs. Here are my disclosures. I qualified in medicine in 1962, which is more than half a century ago, and at that time we had two anticoagulant drugs. We had heparin and warfarin. And since then, I've watched with you the evolution of antithrombotic therapy with the introduction of new drugs that have had a big impact on the management of patients with thrombosis. I think the first big change was the introduction of low molecular weight heparin in the late 1980s, and subsequently the development of new antiplatelet drugs, which have had a very important impact in the management of coronary artery disease. But now in the 21st century, we have the development of anticoagulant drugs that target single coagulation factors. And these drugs, as you have seen already, are having important impacts in the management of patients with such disorders as atrial fibrillation. Here are the most advanced and the ones that are currently approved in most countries. There's the direct thrombin inhibitor, dabigatran, the factor 10 inhibitors, rivaroxaban and apixaban, and to some extent edoxaban, which is really only approved in Japan so far, but has good data, and I'm sure that it will be approved in other countries. When you think about these drugs, because they're all very effective and they are becoming widely used across the spectrum of thromboembolic diseases, there are things that we think about as doctors. One is management of bleeding. Can we measure the new anticoagulant drugs? Because we're all used to monitoring warfarin with the INR. And a question that is raised at virtually every symposium on the new anticoagulant drugs: what about an antidote? Now let's start with this. All anticoagulant drugs cause bleeding. When you look at the vitamin K antagonists, lots and lots of literature tell us that major bleeding occurs in about 1 to 5% of the patients who receive a vitamin K antagonist, and alarmingly, about 0.5 to 1.2% of patients have an intracranial hemorrhage. 1 in 100 of our patients who receive warfarin, no matter how carefully we monitor it, has an intracranial hemorrhage. Now, the important thing about hemorrhage in patients who have atrial fibrillation is associated with a high risk of adverse outcomes, such as a 3 to 5-fold increase risk in thrombotic events and death. Therefore, it's incumbent upon us as clinicians to ensure that we optimize the management of antithrombotic drugs to reduce the bleeding risk. So what can we think about in the terms of management of bleeding? First of all, and most importantly, we should prevent it. Secondly, if a patient bleeds, we need to know how to manage the patient. What about prevention? Well, first of all, there's a number of things we can consider. The anticoagulant selection is important. The patient themselves, the risk of bleeding, and the dose that we administer, and appropriate management of interruption, because 20% of our patients on long-term anticoagulants require interruption for a surgical procedure, for example, and that's a period where there is a higher risk for bleeding. Let's look at anticoagulant selection. When you look at the new anticoagulants, which are now called non-VKA oral anticoagulants, or NOACs, you can see that there's a trend towards less bleeding, and with some of the drugs in the doses used and in the population that was tested, there was less major bleeding. But it is interesting that there's a difference in the pattern of bleeding, whereas we see less major bleeding, we see a little bit more in the way of gastrointestinal bleeding. And that's not a surprise, because what are we doing? We're giving an active anticoagulant drug directly into the gastrointestinal tract, whereas warfarin requires to be absorbed, metabolized, and have an effect systemically. So it's not a surprise that there's a little bit more gastrointestinal bleeding, but it's not really in terms of numbers a major problem. But here I think is the most important thing of all. There is less intracranial hemorrhage with the NOAC drugs in comparison to warfarin. And to my mind, this is a very cogent reason to consider the new anticoagulant drugs in most patients who are on long-term treatment. In addition to that, if a patient bleeds on a novel anticoagulant drug versus warfarin, the outcome is better. Look at the mortality in the patients who received dabigatran versus warfarin in the RELY trial, a p-value of nearly significance, 0.052 in mortality. And similarly, a 50% reduction in the risk of death following bleeding in patients receiving apixaban versus warfarin. So, if you want to consider my first point, choice of anticoagulant drug, it is quite clear that the novel drugs have an advantage over warfarin. What about the perioperative management of the patients on these new anticoagulant drugs? We're still in a stage of equipoise with respect to bridging, etc., but we now have to consider interruption of the new anticoagulant drugs, and when we do this, consider three things: the drug, the patient, and the procedure. Thinking about the drug, talk about the half-life, the route of clearance. To some extent, all of these drugs are excreted by the kidney, and in the event of renal insufficiency will accumulate. So you have to know the patient's renal function. You have to know what concomitant drugs he's taking. The procedures themselves have different bleeding risk, and hence you have to know the bleeding and thrombosis risk of the procedure. Now there's a...
Dear ESC Congress 2014 participants, we kindly inform you that the inaugural session will commence in 30 minutes in Rome, Barcelona, located in the central village.
I'll be finished before that. Here is a publication by the European Heart Rhythm Society with guidance on how to manage patients who are on the new anticoagulant drugs. And you can see that it really depends on creatinine clearance, but it's obvious that the factor 10 inhibitors are much more simple in terms of how long to discontinue the drugs prior to the procedure, and a bit more complex with the dabigatran because it is much more dependent on renal excretion. We have to know when to resume after the surgical procedure, and to consider in the patients who are at high risk of thrombosis, venous thromboembolism, to give the patients low molecular weight heparin, because we have no evidence that the new anticoagulant drugs are effective in general surgery, although they are in orthopedic surgery. Again, you have to consider the state of hemostasis, considering the reintroduction of the new anticoagulants. I also want to turn to the question of monitoring. The new anticoagulant drugs do not require monitoring. They have a stable dose response, and the fixed dose is appropriate. But many doctors, of course, have been used to monitoring anticoagulant drugs. Monitoring implies a dose adjustment according to the test. This is not necessary with the NOAC drugs, but the question is, can you measure them, and will it be helpful? In some clinical settings, I think it will. You can measure the drug or the drug effect in bleeding patients, overdosing, questions of compliance, urgent surgery, theme body weights, children, and renal insufficiency. Things that we are already doing with low molecular weight heparins, which were also introduced as drugs not requiring monitoring. Can you measure them? Well, there are ways that we can. We can do specific assays for dabigatran, rivaroxaban, and apixaban, and to some extent they have an effect on global tests of coagulation. For example, there's a linear relationship between the concentration of rivaroxaban and the prothrombin time using sensitive thromboplastin such as neoplastin plus. So you can measure them, but it gives you a quantitative value and not a qualitative value and not a quantitative value. I think the future is point-of-care testing, and I know that there are being specific tests for the individual new anticoagulant drugs which will be available on point-of-care testing for us in the future. Now, turning to the management of bleeding, what do you do if a patient bleeds on vitamin K antagonists? You don't give them any more. You give them vitamin K, resuscitate in the usual way with mechanical compression and surgical methods if necessary. But if the patients continue to bleed, what do you do? Well, the simplest way is to replace the clotting factors. And in the past, this was largely done with frozen plasma, and you can see the characteristics of frozen plasma listed here. And now, more and more, we have the availability of prothrombin complex concentrates. Here's a study from the United States looking at the use of a prothrombin complex concentrate versus a vitamin K antagonist, and you can see, against plasma, and as you can see, the fraction of patients without correction is much higher in the patients receiving plasma, and very much a dramatic effect with the PCC. And this shows you the effect in the bottom on the median INR, demonstrating that the PCC is much more effective and has much less in the way of fluid overload than plasma. What do you do if a patient bleeds on a NOAC? You don't give them any more, you don't give them vitamin K, and you resuscitate in the usual way. If they continue to bleed, what do? You can either activate coagulation, you can remove the drug, or you can neutralize the drug. Removing the drug, I would just briefly say, is with dabigatran, which is dialysable. But really, who wants to do that on a routine basis for a bleeding patient? So, you may want to activate coagulation. Recombinant factor 7, prothrombin complex concentrate, or an activated PCC are available. Do they work in the new anticoagulants? Well, we have some early studies in human volunteers, this one published in Circulation, looking at the reversal of rivaroxaban and dabigatran with PCCs. And I'll just show you one of the results of the study here. This shows you the prolongation of the prothrombin time with rivaroxaban and rapid reversal with the administration of PCC. So to my mind, if the bleeding is associated with an anticoagulant effect, and if you can reverse that, it is likely that it will be clinically effective. Now, the big question is antidotes and new anticoagulant drugs. I think that most of us would like to see these for bleeding, emergency intervention, even elective intervention, and in patients who have an overdose. Are there antidotes? Well, there are antidotes under development. We have idarucizumab, which is a specific antidote for dabigatran, a drug called PER-977 so far, a small molecule, which is a universal antidote to anticoagulants under development. But the most advanced one is adexanet alpha, which is a human variant of 10A, and it targets the factor 10 inhibitors, a competitive inhibition, and it results in rapid near-complete reversal of factor 10 inhibitors. Here is just a slide showing you the phase 2 clinical trial with program with adexanet. It is being tested to see the effects on all of the new anticoagulant drugs, apixaban, rivaroxaban, enoxaparin, betrixaban, and edoxaban. A volunteer study with varying doses of adexanet alpha. We have the data already with the apixaban study, and as you can see here, there is a really nice dose response with respect to inhibition of anti-factor 10A activity and a reduction in the apixaban free fraction. Again, a dose response to adexanet alpha. So it is very effective in reducing or neutralizing the effects of factor 10 inhibitors. There's an ongoing program with adexanet alpha. The FDA has designated this breakthrough therapy, so it will not require very much in the way of phase 3 data. But there are the phase 3 clinical trials underway, one called ANNEXA-A with apixaban and ANNEXA-R, which is rivaroxaban. So we are eagerly awaiting the results of these clinical trials. So colleagues and Mr. Chairs, the NOACs provide an opportunity to minimize the growing burden of preventable thromboembolism. Reductions in both stroke and bleeding translate to important benefits for our patients. Most patients can be managed without specific antidotes, but the specific antidotes in development will provide reassurance to us as clinicians. The most important thing of all is education to overcome the fear of bleeding as a barrier to appropriate anticoagulant use, and this is important. Thank you very much.